Hi, my name is Neil Appana. I'm a specialist gynecologist in Hamilton in New Zealand. Welcome to my series of educational videos in gynecology. Today we're going to talk about hysterectomies. Together with this video, I would suggest you watch the videos on laparoscopies or laparotomies, depending on whether you're having keyhole or open surgery. What is a hysterectomy? A hysterectomy is the removal of the uterus, i.e. your womb. There are a number of different types of hysterectomies and a number of different ways in which to perform this procedure. A standard hysterectomy used to involve removal of the body of the uterus and the cervix, but recent evidence has led to the removal of both tubes being offered to patients undergoing hysterectomy. A subtotal hysterectomy is the removal of the uterus without removal of the cervix. A total hysterectomy involves removal of the uterus and the cervix. A total hysterectomy with bilateral salpingectomies involves removal of the uterus, cervix, and tubes. A hysterectomy these days is usually performed with conservation of the ovaries. However, occasionally there will be need for removal of the ovaries. This would be called a total hysterectomy with bilateral salpingo or oophorectomies. More radical surgery, which involves removal of the lymph nodes and some of the vagina, may be performed for cancers in the pelvis. This includes a Vertines hysterectomy and a radical hysterectomy, and are usually done by subspecialist gynecologists. The procedure may be performed either totally laparoscopically assisted vaginally, totally abdominally, or totally vaginally. The method chosen is usually dependent on what the surgeon is most comfortable with. The operation is usually performed with the intention of preserving your ovaries, and unless a life-threatening condition of the ovaries is encountered, your ovaries will not be removed. This will have been discussed with you in depth. The cervix, or neck of the womb, is usually also removed, but in some instances where technical difficulty is encountered, this may be left behind. You will be informed if this occurs. Laparoscopic surgery involves 3 or 4 tiny incisions in your abdomen. In view of the shorter hospital stay and faster recuperation time, it is the preferred method of surgery. However, technically it may be difficult to perform, and the procedure may have to be performed via bikini line incision. This will also have been discussed with you in depth. Indications. There are a number of reasons why your doctor would have suggested you have a hysterectomy. Common reasons for this include abnormal bleeding, fibroids, prolapse, endometriosis, and malignancies. This will also have been discussed with you in depth. Complications, risks. Any operation has anesthetic risks. In fit, healthy females, these risks are minimal. Any operation has the risks of bleeding and infection. Excessive bleeding following laparoscopic hysterectomies is rare. The collection of blood may also occur at the top end of the vagina, called a vault hematoma, and this may take some time to dissipate. Infection rates run at about 2%, the majority of these infections being wound infections. Occasionally more serious infections can occur, including pelvic abscesses. Antibiotics are usually prescribed to you perioperatively and during the operation as well, during prolonged procedures. If you are at high risk of infection, you may also have antibiotics for a few days after the surgery. Organs at risk of damage include the bowel, bladder, blood vessels, and the ureter. Short-term complications include urinary retention and deep vein thrombosis. Your doctor will usually use a method to decrease the chances of this happening. I use a stocking compression method with a calf pump. Bruising is fairly common, as well as shoulder tip pain, if the procedure is done laparoscopically. If there is a high risk of damage to your bowel, an MRI will be done pre-surgery, and you will need to see a surgeon prior to surgery. The surgeon may be required to be in theatre or just available. Similarly, if the bladder or ureter is involved, a urologist will need to be involved. After the operation, you may have slight bleeding and a discharge for up to 10 weeks after the operation. You should not have an offensive discharge, heavy bleeding, or significant pain after surgery. I will have ordered pain relief for you, and you should ask for this as soon as you require it. You will usually be given a patient-controlled analgesia pump. You may have a catheter left in the bladder. This happens if the bladder is manipulated a fair bit during surgery, and it is usually left in for 24 to 48 hours. You'll be in hospital for about 3 days if your surgery is done laparoscopically, and up to 6 days if it is done abdominally. You should try to have 6 weeks of rest with no heavy lifting or strenuous exercise. You should be aware that you may need up to 8 weeks of work after hysterectomy, usually much less if it's done laparoscopically. In general, there is little bleeding after hysterectomy. You should use sanitary towels but not tampons. If you have heavy bleeding, bad pains, a smelly vaginal discharge, or temperature, you should contact me or your doctor. Also advise you to not have sexual intercourse for at least 4 weeks, or at least until the bleeding has stopped completely. After hysterectomy, there's a possibility of getting a urine infection. Watch out for cystitis, and if it does occur, drink plenty of fluid. If symptoms persist, contact me or see your GP. The risks of this procedure are minimal, but very occasionally injury may occur to your ureter, which is a tube leading from your kidney to your bladder. If there is any risk of this, a scan or x-ray of your abdomen will be arranged while you are in hospital. Very, very rarely, a repeat operation may be needed to unblock this tube. You may have a tube sticking out of your tummy for drainage. This is left if there is more than the average bleeding during the operation, merely as a precautionary measure. I very rarely use this. Occasionally, there may be a fair amount of bruising around the skin incisions. These usually disappear completely in 3 to 4 weeks. It is aimed that you are discharged on day 3 to day 6, depending on the procedure. If you have problems such as bad pain, increased bleeding, temperature, or generally feeling unwell, please contact me or your GP. You should not drive until you can sit comfortably in the seat with the seat belt across you. You should be able to turn your body as though to reverse, and you must be able to perform an emergency stop. Similarly, if you do too much too soon, you will know all about it. Rest and avoid any lifting. I will review my rooms at 2 weeks and at 6 weeks after the operation. The sutures that I use for laparoscopic surgery are non-absorbable and will need to be removed from the tummy. The internal sutures are all absorbable. Disclaimer. Without having examined you personally, it is impossible for me to make a diagnosis or advise treatment. All information provided here is generalized and for educational purposes only, and decisions based on this should not be made without consulting your own medical professional. I assume no responsibility for you taking advice rendered here without me having had a physical consultation with you.